Bonsoir tout le monde. Welcome everyone. Bienvenue. I'm very excited to be here with you tonight. Partially for personal reasons, I have benefited immensely from the guidance of Claire Webster and from Dr. Gauthier and Dr. Moret with my own caretaking journey with my parents. So I'm thrilled that they're back. It's been since before COVID. You can't hear me? No? I'm getting a can't hear you. It's been since before COVID that they were here in person. We've done some online work, but ça fait quelques années maintenant qu'ils sont ici avec nous autres. This is such critical information. I am so grateful that they're here to share this with our community. And knowledge is power. So much of this is about what to expect, how to get through it, where you can lean on people for support. So I'm very grateful to have Claire as someone that I can lean on for support. But I also want to thank everybody at our community events. Merci tout le monde aux bibliothèques et événements communautaires who really put together these events with the community in mind for what they need and what they want to talk about and hear about. So a big thank you for them, for the support that they give this community. So now I'm going to hand it over to Daniel, who's going to give us a little bit of an introduction de qu'est-ce qui se passe ce soir. Puis je pense que ça va être plus en anglais, mais on pose des questions. Si c'est bilingue, en français, c'est pas de problème. OK. Merci. Welcome.
Merci, Maire Smith. Bonsoir à toutes et à tous. Welcome. Good evening. My name is Daniel Miguez de Luca. I'm the programming and outreach librarian at the Westmount Public Library. Thank you all for being here. We also have several people at home attending on YouTube, live streamed. This event will be recorded and available on the library's YouTube page afterwards. So just to let you know. This is the second time that the City of Westmount and the library collaborate with McGill University's Dementia Education Program to give a lecture here in Victoria Hall. We did one in 2019, so pre-pandemic days. I would like to take an opportunity to thank the team at the Dementia Education Program for collaborating with us, especially Diane Widener and Maria Vincelli, who are in the back today, who worked with us to plan this evening. We all know from statistics that dementia rates are increasing in Canada and in the world. And as this happens, education and awareness are essential tools to work through and work together through this. And so the City of Westmount and the Westmount Public Library both strive to organize events and programs that achieve this purpose, to educate and inform and support with events like tonight's lecture and other events too, like a program at the Westmount Library for people with dementia called the Tales and Travel series, which I'm proud to be a facilitator of for the last 7 years. So just a side note, this event is one event happening here at Victoria Hall of many. So we have concerts, lectures at Victoria Hall and at the library, different activities. The best way to know what's going on in these two spaces is to sign up to the library's e-newsletter, which goes out once a month. You can do that on the library's website, which is westlib.org. So I hope to see you at many more events throughout the summer. So I'd like to introduce our three speakers who are just down there. Perfect. So our first special guest panelist, our first. This is just the order I have them. I'm not even sure what order you'll be sitting in, but yeah, we'll start with Dr. Serge Gauthier, who is an academic co-lead of the Dementia Education Program and Professor Emeritus in the Department of Neurology and Neurosurgery and Department of Psychiatry at McGill University. He is a clinical neurologist specializing in the development of new tools for diagnosis and treatments for people living with Alzheimer's disease. His contributions to research include design and implementation of randomized clinical trials in order to establish the safety and efficacy of cholinesterase inhibitors, muscarinic agonists, and agents possibly modifying progression for Alzheimer's disease and vascular dementia. Our second panelist, Miss Claire Webster, works in collaboration with the Division of Geriatric Medicine and the Faculty of Music. No, that's the faculty I studied in, excuse me. The Faculty of Medicine. The Faculty of Medicine and Health Sciences at McGill University, where she is the founder and ambassador of the McGill Dementia Education Program and McGill Cares, a webcast series designed to support families and family care partners. She's a certified dementia care consultant, certified professional consultant on aging, and conference speaker and educator in the field of caring for an individual with dementia. As a former care partner to her late mother, who had Alzheimer's disease, Claire has lived experience on the impact this illness has on a person living with dementia and the ripple effect on family members. And third on the list is Dr. José Moret. Dr. Moret is a professor of medicine and academic lead of the Dementia Education Program at McGill University. He is a senior scientist at the Research Institute of the McGill University Health Center in the Metabolic Disorders and Complications axis. His research interests relate to the assessment of protein metabolism and cellular regulation at whole body and muscle levels, and of protein requirements with age, frailty, and diabetes. He's also participating in several studies involving the nutritional assessment of elderly persons with the aim of improving their nutritional status and level of physical function. So, without further ado, please join me in welcoming our three panelists.
Bonsoir. Bonsoir. Good evening. Guten Abend. There's at least one person online who speaks German, friend of my wife. Thank you for coming despite the terrible weather and the road construction. I'll just take a second to tell people who don't have the books to pick them up at the back. Diane and Maria will make sure you get one in English or French. And if you wish, you can go online, and there's 13 other languages you can choose from. Parfait, merci. Including Ukrainian. Long live Ukraine. So my topic is, sorry. So I'll look here now, not at the screen, so I can look at you, see if you're asleep. By the way, Maires, would you like to have multiple choice questions? Just for fun, people can have fun with this? Just to make it more exciting? Okay, I'll tell you the questions as we go along. I'll make them up and we'll follow up with that. Because you're a smart group, we should really try this first in Westmount. Yes. So my topic is the medical side of things, and then Claire will talk about the human side, and then José will talk everything else, including prevention. So hang on. I'm asked to always describe what is dementia. Notice that in the French booklet, it's called something else, trouble neurocognitif. So just be aware, in Quebec, it's an administrative decision by the RAMQ to use this term. It's also used in some English literature. So trouble neurocognitif majeur ou mineur, minor or major neurocognitive disorder. But we decided to call it dementia because it's more familiar to people around us. And the other point to make is that there's multiple causes for dementia. So what is dementia first? Well, in a nutshell, it's a decline in your cognitive abilities. It's not only memory, it's also looking for words, as I'll describe, looking for your way in the city, and it impacts your daily life. So dementia is usually progressive, but it could be after a stroke and then you're stable, or a head injury and then you're stable. But what we discussed today is more like Alzheimer and related conditions. So you see Alzheimer is there as the most common over age 65, condition causing dementia. But notice there's Lewy body dementia, which is Parkinson-like, with visual hallucinations and slowing of walking and fluctuations within the day. Vascular dementia is relatively rare now because people really take care of their blood pressure and diabetes and other vascular risk factors. What we have, especially over age 85, is people with Alzheimer and small strokes. So it's called mixed vascular and Alzheimer dementia. Frontotemporal is rare. It's usually people in their 50s or 60s, a little more women than men. And it's either you look for words, progressive aphasia, or you have difficulty interacting with people, more like a behavioral kind of change. And other dementias could be infectious, it could be a mix of head injury, drinking, and so on. But for today, we're going to focus on Alzheimer, but be aware that most people over age 85, if you say they have Alzheimer as a cause of their dementia, there's also perhaps a bit of stroke mixed in, a bit of Lewy body, Parkinson-like mixed in. Okay? It's rarely just one cause. Okay. Early detection. So Claire always wants to say, look, if you have any symptoms, just see a doctor. If you don't have one, see your pharmacist. It's the easiest health professional to meet nowadays. And maybe you get lucky, you see a nurse who knows about troubles neurocognitifs, and then you get to see the family doctor. Each group de médecine familiale is supposed to have one family doctor who has a special interest and expertise, and you'll get tested, and it may require more than one visit. And there's a lot of modifiable risk factors that José Moret will talk about, so I'll say no more about that. So, if you have symptoms, just go for a checkup, and you may be told, look, you're depressed, and you're hard hearing, and you drink too much. Okay, yeah. Normal aging. So, to reassure people in the room who are hesitant sometimes, what's your name again? But at least I know you, and I know where I met you, and then it comes back, right? Sounds familiar? Of course, if you start calling your dog with your grandchildren's name, I don't know. It happens to me, so don't worry about it. Slower processing speed. So I don't know if you watch shows on TV where you have to think quickly, smart games, and you have to find letters and we're slower, aren't we? Yeah. But at least when they find it, they say, oh, yeah, I knew that word. Yeah. Finding words happens to all of us. It's a tip of the tongue thing, but it comes after a while. There's a slight delay. That's part of normal aging, and we know why now. There's a change in the structure of the brain part called hippocampus. There's a good research being done at McGill about that, what happens in our hippocampus. But it doesn't mean that you're going to progress to dementia. Good judgment, normally someone who's used to making financial decisions, who's good with social interaction, this will be preserved throughout their old age. And we're supposed to remain functionally independent, but as José will say, well, you may have actually arthritis and you may be at risk of fall and there's other things happening. It's not just dementia outside of a whole body kind of thing. And that's one thing geriatricians are very good at. Look at the big picture. Neurologists tend to look at the brain only. Yeah. Now, symptoms of dementia that may occur. Everybody knows about memory decline. So what would be significant is things you used to know and are important, such as I have to go pick up the grandchildren at the school at 4 o'clock. And then you forgot once. Okay, once is no big deal, but it's 3 times. Okay. It's worth checking what's happening. If you used to play bridge and then you forget what the contract was and you were very good at it, it's significant. My wife used to tell me in her bridge club, you're going to see this lady at your clinic in a year. And she was right. So it could be subtle change in complex hobbies. Confusion with time and place. Of course, once you're retired, it's less obvious what date and even what day of the week. For men, we rely on the garbage day. It's a secret among men. Eh? Oh yeah, it's Monday, it's recycling day, and Thursday, it's garbage day. Yeah. Language. So someone who looks for words, but it's now causing an embarrassment to that person, and they withdraw socially. That's significant. Okay, so looking for words, not just the tip of the tongue thing, but cannot be part of a conversation anymore. that could be significant indeed. Poor judgment, that's all relative, but especially forgetting to pay bills that are due, and complaining about people looking over their shoulder. That may affect personality and cause some anxiety, depression. Difficulty completing familiar tasks is an example that's easy. So the lady who used to have the kids coming for dinner on Sunday, every Sunday for lunch, now can't do it. Too complex to prepare the meal, to plan the meal, etc. So she may say, I'm not interested anymore, I'm too tired, whatever. And withdrawing from social activities, this is important. So this is important, especially in this context, because you're all socially connected, but if you know someone who's now not coming anymore, find out if it's a physical problem, maybe it's arthritis that's acting up, but it may also be social withdrawal because of fear of not being able to keep up with conversations and so on. What's less talked about is less common non-cognitive symptoms in the early stage of dementia, and that would be conspiracy theories. If I cannot find my wallet, I'll blame the spouse or the neighbor, call the police. That's just an example. Depression, mood swings could be early features of dementia, even before your memory declines. Disregard for personal grooming is rare for Alzheimer in the early stage. It's more in frontotemporal dementia. Delusions, false beliefs, especially jealousy. So for some people, Claire may talk a bit about that because it's a common issue. The poor man is 90 and he's accused of having 3 girlfriends. I wish, he says. Yeah. It's very hard to live. Verbal physical aggression is very unusual in the early stage of Alzheimer, but it could be a feature in someone who's drinking too much alcohol with a bit of Alzheimer and stroke mixed in. And sleeping difficulties, it's usually a bit later for Alzheimer, but sundowning, it's a term you've heard before, and I think Claire will talk about that. It's this difficulty around when it gets darker. For us, it's mostly November because of the winter equinox. When around 5 or 6, people get a little agitated, and in some countries they have neon lights everywhere because they want to prevent this sundowning. So that's the introduction to the symptoms. You see, they can be quite varied. It's not just memory, okay? Now I'll just say a few words about the natural history. And then later, if you're interested in the question period, we can talk about how do we modify that natural history with the new treatments that are coming up. So this is the usual progression. You may have on the left mood changes. So that's now called minimal behavioral impairment, MBI. There's a medical term for that stage of Alzheimer where you're a bit anxious because you're not as sharp as you used to be. You may be depressed because you're withdrawing from social activities. You may be suspicious a little bit. It could be a mix of things, but your memory is still fine. Then there is this line coming up, cognitive function. It's, in the case of Alzheimer, usually memory for recent events. Notice that the mood is getting better because now you forget that you have a problem. It's called anosognosia. Claire will talk about that. And then the functional autonomy. Notice the lag time as you move to this side, as you move to the right. You have difficulty now preparing meals for the family. You have unreliable timing for picking up the grandchildren. It impacts your daily life. So that's dementia by definition. Notice there's a lag time between memory complaints, decline that you can measure with a paper and pencil test, and then you lose some independence. And that could be years in between those steps. And that's what we're going to stretch now with the new therapies, delay progression to full-blown dementia. And then you have the second phase of what we call behavior, severe behavior changes. In the course of Alzheimer, it's usually after 3 to 5 years, and it could be not recognizing the house, the spouse, various things. And then they get better with time. As the last stage comes, and it's Parkinson-like, you're slower to walk, you're at risk of difficulty swallowing and falling. Now I'll put some illustrations just to make this more lively. So this is a lady who's multitasking. She's cognitively normal if we do a paper and pencil test, but she has no complaints. And maybe she complains the odd time on Friday. What am I supposed to be doing today, this weekend? It's okay. Subjective cognitive decline, normal. You see she's doing different things, coffee is made, etc. Now, same lady 3 years later. Oh, what's my password? But she knows what a password is for. She knows where it is. It's in her agenda or wherever. But it could be, it's a change. Okay. Now the daughter's worried. That's a red flag for us. Claire will tell you that. If there's somebody in the family that starts to worry about the difficulties with the lapses in attention, memory, take it seriously. And then another 2-3 years, now she needs assistance for handling finances. Hopefully she already went to the notary to get a mandate written up, power of attorney at the bank, and as you see, she needs assistance. She's still able to live alone, probably cook routine things. Another stage, another 2 years. Now it's called moderate stage, where she needs assistance to select the clothes, to put them on. She probably can live alone, but not 24 hours. And severe stage, there's physical incapacity now. She needs a cane, she's at risk of falls, and she will get probably an aspiration pneumonia within the next 6 to 12 months. So this is a span of 8 to 12 years from the minimal symptoms to dying from an aspiration pneumonia. Now, workup. A few words. This is the wisdom that Claire has put together over the years, and she says, arrive prepared. She was not prepared. So she shares now, okay, write this down. Write the medical history of the person you accompany, list of medications, or just bring the pills in a bag, for God's sake. Okay? Over the counter or prescribed, just bring them all. Try to list the symptoms that are most troublesome right now. And don't go longer than 5, because the doctors will say, oh, just one at a time. And whatever you bring on a paper, don't go more than 1 sheet of paper. Otherwise, the doctor will go crazy. Okay, yeah. List whatever the person is using, hearing aids, visual aids, maybe a walker. Now, here Claire is stepping to, okay, when the diagnosis is made, make sure you don't leave the office without having clear steps. And that won't happen on the first visit, let's be clear. But it has to be in your mind all the time. You don't leave with just a diagnosis, good luck, Mrs. Webster, which she'll tell you about. It has to be, okay, like diabetes, like cancer, what's next? Okay. And then practical questions, depending on the stage the person is at. Can she continue driving? How do we protect that person for managing finances, and so on. So this is the MOCA. This is the Montreal Cognitive Assessment. It's made in Montreal. It's used worldwide. There's 3 versions in Mandarin. It's used worldwide. So whenever we go to Congress around the world, Montreal Cognitive Assessment. We hear the word Montreal all the time. It's nice, eh? It's used for screening. It's out of 30 points. Normal people get 26 or above. Trump got 31 out of 30. Don't ask how. He really said that. It's very useful, but there's a cultural bias. It was developed in North America, especially East Coast, so Montreal and Boston kind of regions. So if you try this test in rural China, the normal is like 16 out of 30. So you cannot just use the test just like that. You have to take into account the culture, and they have different animals and different word symbols, etc. So it has to be modified based on who you're testing. Now, this is new. It was in the news last Friday. This is a question for the exam. What is the new blood test for Alzheimer? So it's called p-tau, phospho-tau, so short, p-tau, 217. So we've been working on this for about 8 years. The blood test that led to this finding, much of the blood comes from Montreal. Through the research done at the McGill Center for Studies in Aging, we have a cohort of healthy people and people with some symptoms. And every year they give blood, spinal fluid, 3 scans of the brain, send the blood to Sweden. So the Swedes helped us to develop this test. It's approved now by the FDA in the US. It's commercialized in the US, and it will be probably in Canada shortly. So careful what you wish for. It's like having a sugar test for diabetes, or the equivalent, the oxyhemoglobin test. If you have a high level of this protein in your blood, it means that your brain has a lot of amyloid and tau protein buildup. It correlates with both proteins buildup. But there may be false positives. You may have high level of that protein in your blood because your kidneys are very slow, or other reasons we have to look into. So careful, it's not going to be a front line this year, but it may be early next year as a tool for people with symptoms and they want to know, do I have Alzheimer's disease, even if it's very mild, because there's something I can do about it. There's prevention, there may be new medications, etc. So will be one of the questions. P-tau 217. Okay. Now the scans of the brain, they haven't changed much in the past 10, 15 years. We do a CT scan, which everybody had at least once in their life for one reason or another. What we look at is, like this is a picture this way of the brain. This is an MRI. It's the same kind of pictures as the CT scan. The MRI is just a little more sharp for details. And what you see circled in red is this hippocampus I told you about. It shrinks with age. That's why there's a lag time to remember things. But you see number 0, then 1, 2, it just shrinks more and more and more. And then then it could be associated with symptoms such as mild dementia, moderate dementia. So that's the part of the brain that we look at on the scan. Is it shrinking, the hippocampus on both sides? The other thing we look at is small strokes that may be silent, much less than before because people like us, baby boomers, have taken good care of their risk factors for stroke. Another kind of scan that we do a lot in Quebec, it's called a PET scan, so positron emission tomography using glucose. That's the scan you use for cancer. So you know of people who had this, the whole body gets scanned looking for hot spots. For the brain, what we do, I'll show you the picture. In red, it means the sugar is in parts of the brain. In the middle, normal, meaning no cognitive complaints, no impairment. It's what's in red means the sugar is there being metabolized. It's an index of synaptic activity. And what you see on the right, AD, Alzheimer's disease, this is someone with obvious mild dementia. And the arrows point to regions where there's much less sugar being used. So that means there's less cells, connections, synapses active in those parts. Especially the top one, this is a pretty classic signature. And in Montreal, we have ready access to glucose PET scan for the brain. It's done at the CHUM, and it's read by the top man in Canada, Dr. Jean-Paul Soucy. If you're young, younger than 70, and your symptoms are very mild, and you really want to know, do I have Alzheimer's, we can do other things. We can do a spinal tap, and we look in the spinal fluid, p-tau, now the protein you're familiar with, is it high? And amyloid is low in the spinal fluid because it's stuck in the brain, paradoxically. There's new things we're looking at, inflammation, proteins that could be there, proteins that reflect neurodegeneration. So spinal fluid, you get a lot of bang for your bucks, especially if you analyze it for all it's worth. The other thing we do, but it's still considered research, is scans of the brain for amyloid buildup and tau protein buildup. So let's say you've had your workup, you've met the doctor at least twice to repeat the MOCA over 6 months, see if there's a slight decline, repeat the history. So in the mind of the clinician, is there a clear evidence of cognitive decline, or was it just a temporary flurry of symptoms because of depression, because of loss of a friend, change of environment, whatever? Does it interfere with daily life? And that could be subtle. Could be the bridge game. It could be planning a meal. Could be forgetting the garbage day for men. Is there depression mixed in? Remember, often there's depression mixed in with early dementia. So what, in doubt, we treat for depression for 3 months and reassess. Are there other conditions explaining some of the symptoms? That's what Dr. Moret will tell you about. Is there kidney failure, heart failure, take too many pills that are interfering with your memory? The drug side effects is something the pharmacists are very good at picking up. There's a special software they use for the side effects that could add up, interfering with your memory, the so-called cholinergic load. And delirium, that would be unusual because it's an acute thing. It's more like over the weekend, the grandfather became all confused, and it's likely he has a urine infection or pneumonia and so on. But someone with Alzheimer's mild stage can have now a new burst of symptoms because of infection or other cause, and you can have a delirium on top of mild dementia. So that goes in the doctor's mind. Now he talks to the family and the person living with the symptoms, and normally he would or she would say, I think this is a mild neurocognitive impairment or moderate or major. Mild cognitive impairment, MCI, is the term used in English, and dementia, mild dementia. Now, depending on the symptoms, the discussion will be, do you want to take an antidepressant? You have some subtle symptoms of depression. Let's try that first. Then second level of treatment with medicines is medicine to increase acetylcholine level in the brain. So that's the medicines we've had for 15 years, all tested here in Montreal and around the world. Donepezil, used to be called Aricept. Rivastigmine, or Exelon, used to be available as a pill. It's now more used as a patch. And galantamine used to be called Reminil. And memantine, also we tested. It's used a little later, around moderate stage of dementia. It helps prevent some of the emerging behavioral symptoms. And unfortunately, sometimes we have to use antipsychotics in low doses for specific behaviors that are not responsive to non-pharmacologic management or antidepressants. I'm at the end now. So what's coming next is medications that take the amyloid out of the brain. So the ones that are being looked at by Health Canada, they're called lecanemab and donanemab. They're approved in the US and some countries like Japan and Korea. They're not easy to use, and we'll talk about that. If they get approved, I'll come back to discuss them. Other medicines are being tested for protein tau buildup, for inflammation, for diabetes kind of changes in the brain. So you've heard about medicines to lose weight. They're also being tested now for Alzheimer's. So lots of things happening right now, and Montreal is right in the middle of this. And education, and there comes the lady who will talk about education, about the condition, the transition now. What do you tell the family? How do you plan for the future? We've had 3 World Alzheimer's reports we wrote together. If you want to really go into depth into the diagnosis, there's one in 2021, and the management 2022, and one about prevention 2023 that José will talk about. And there she is. There you go.
Thank you. Thank you. So, can everybody hear me well? Well, thank you, Mayor Smith, for inviting us once again. And I only have 30 minutes, so what I'm going to do tonight is, in the 30 minutes, really highlight probably the most frequently asked questions that family members have when you're really having to take care of a person who's living with dementia. I've been embedded in this field for now 20 years. It's amazing how fast time goes on a personal and professional level. I was a caregiver to my late mother who had Alzheimer's disease for a period of 10 years. And I've recently become involved in the care of a very great dear friend of mine who's only 62 years old, who's been diagnosed with Alzheimer's disease. So I find myself once again involved as a caregiver, but this time probably with a lot more tools than I had 20 years ago. So I do this work because of my own experience as a caregiver to my late mother, who was diagnosed with Alzheimer's disease with a mix of vascular dementia. She was diagnosed at the age of 74, but in retrospect, she probably began showing symptoms at the age of around 68. And I represented the sandwich generation caregiver. So I was an only child. My father had passed away in 2005. And not long afterwards, my mother started displaying some symptoms that I'll tell you about. I had 3 young kids. I was a resident of Westmount at the time, soccer mom, working mom, trying to be the best wife, mother, friend, but inevitably, as many caregivers are, I put so much pressure on myself, and I ended up suffering from a severe burnout. And part of the contribution to the burnout, I would say, was as a result of this prescription of care that I did not receive. So at the time, I'll just go back one slide. At the time when we went to see a neurologist, this was the only words of wisdom that we were provided. It wasn't, here are the next steps, here's what we need to do, but this was it. And that was back in 2006. And since then, I've worked with hundreds and hundreds of family members. And sadly, too often, people are hearing the words, good luck, see you in 6 months. it's normal aging, right? And dementia is not normal aging. And there's what we call ageism, where oftentimes healthcare professionals will see somebody who's in their mid-80s and automatically say, oh, well, it's just old age. Dementia is not normal aging. And, writing the world reports as we did, as Dr. Gauthier mentioned, we had to survey people living all around the world to understand what some of the biggest challenges were. And sadly, this was coming up over and over again, is that people, whether it's patients, caregivers, were not being provided with the right information about how to deal with this disease. So I'm going to just share this this important information, because this doesn't only apply to dementia. I would say this would apply to any disease that you're dealing with, a family member, yourselves in the future. And I think that as patients, we have the right to understand the disease that we're dealing with. And too often in the healthcare profession, when we are in a doctor's office, they don't always discuss the disease in language that we understand, okay? They don't always communicate to us in language that we understand. And so it's important that you ask questions. Now, unfortunately, with our healthcare system, the family doctors have to see 6 patients in 1 hour. That means you have 10 minutes to see the doctor, okay? And so it's important that you arrive prepared. As Dr. Gauthier showed before, we have to arrive prepared, right? So we want to understand the disease. We want to understand what our treatment options are. What are the resources that are available in the community that could help us? Depending on the type of illness that you have, there may be clinical trials available, right? Depending on the type of illness, it will impact a person's safety at home or at work, right? Oftentimes, diseases like dementia involve legal and financial planning that needs to be done sooner than later. And a lot of people have questions about end-of-life care. So dementia is a disease that has a tremendous ripple effect, not only on the person who is being diagnosed, but on the family members. So as I was watching my mother unravel, my children were watching me unravel, right? Because it has an impact everywhere. If you're a sandwich generation caregiver that is still working, you know that you're receiving those calls at work constantly, whether from home or if your loved one is in a long-term care, you're constantly being interrupted. It has an impact on the finances. The number one stress that I hear caregivers say is how expensive this disease is to manage financially, right? It has an impact on people's social lives, and it has an impact, as we see now, on our healthcare system. And, I'm going to provide you with some words of advice and wisdom, as I say, but at the end of the day, it's a disease that is ever evolving, okay? So the strategies that you're going to have in place when the person is first diagnosed are going to constantly be changing, right? So what you're going to put in place today will change in 6 months, and in 6 months it's going to change again and again. So it's a disease that requires a lot of patience on behalf of the family members. You have to be creative. And it requires a lot of empathy, which is not always easy. But I cannot emphasize how much it requires to adaptation. And the patient isn't the one that should be adapting. It's the family that has to adapt to the ever-evolving evolution. And as Dr. Gauthier mentioned, it's a disease that can last anywhere from 8 to 12 years. So you are constantly having to change and adapt what you're doing. The biggest role that a family member has is that of an advocate. Okay, so as the disease evolves, the person will lose their ability to communicate, to use their words, to communicate their needs, their emotions, their physical needs, everything. And so the number one role of the family member is to ensure the quality of care of the person, that they are safe, that they are clean, that they are happy, that they're well looked after. And it doesn't mean that, okay, if you're doing a transition from home to a residence or long-term care or to a hospital, that, oh, my job as a family member has ended. Not at all. You are constantly advocating for the care of that person, right? I spoke to a woman today her husband has already been placed in the public system, but because of the lack of resources, she's finding herself constantly going in the evening. She's worried about his safety. She had some help that was going during the day, but now this person is sick, so she's got to go, right? So you are constantly advocating, right? And so it takes a lot of energy on behalf of the caregiver. And unfortunately, with all the hope that Dr. Gauthier and Dr. Moret will talk to us about, there's still no cure. It's not like cancer where you can have a few rounds of chemotherapy and you wipe out this illness. That doesn't happen with dementia. So the only way to navigate it is to have the knowledge, to understand what the disease is, and to prepare what's coming next. So if a person is in the early stages, you have to understand what's in the middle stage. If they're in the middle stage, what's in the next stage, right? If you're caring for somebody at home, you need to do your research and understand, how do we navigate the healthcare system? How do I get home care support? What are the long-term care residences in my community that will able to support me if I can no longer take care? So knowledge is the most powerful resource. I had no prior affiliation with McGill at all. I was somebody that was just very passionate about the importance of education, and I was very disappointed to hear so many people not being properly educated by the healthcare professionals. And I said, well, I live in a city with one of the best medical schools in Canada. How could I maybe go and teach the medical students? And I had been invited as a guest lecturer in 2011 at the School of Physical and Occupational Therapy. And a few years later, I had the opportunity to meet the former dean, David Eidelman. And I just said, I want to create this program at McGill. And there you go. And I have had the gift of having Dr. Moret and Dr. Gauthier with me. So our mandate is to really educate the medical students of the future, because that's the only way you're going to change the healthcare system, right? It's educating the students of the future. So to share a little bit about my own personal story, dementia doesn't only start with memory. My father had passed away in 2005 of congestive heart failure. I grew up in a home watching my mother be a caregiver to my father my whole life. My father was really not well. So when my mother started having these behavioral symptoms, I blamed him. I said that it was his fault, okay? All the stress of watching my mother care for him. But it was really becoming, after my father passed away, I really noticed that my mother wasn't able to manage her finances. She was making significant errors. And this is something that I really want to highlight, is the seeds of dementia can begin with a person making significant financial errors, okay? Donating to charities that you would have not have donated to. Signing off property, signing off your, giving donations of thousands of dollars to charities that you may have not done. So getting scammed, okay? When my mother was diagnosed, we didn't have all these text scams and email scams. So the seeds can begin with significant financial errors, and that's how I started noticing some changes. When Dr. Gauthier mentioned language changes, well, my mother was from Finland, and she started speaking to Finnish to me, and I don't speak Finnish. I never learned how to speak, right? And she wasn't aware of that, right? There were these conspiracy theories that I'll speak about in a second. My mother was a big tennis player. I took her to the Rogers Cup in August, and when I went to pick her up, she was wearing high heel shoes and a winter coat, right? And it was also the way she was speaking to my children. My children were young, calling them idiot, telling them to shut up, right? So there was all these changes. But at the time, I didn't know, who do I go see? And this is another challenge that people are going to encounter is, because these were more behavioral issues, I was thinking I need to take her to see a psychologist. And what Dr. Gauthier didn't mention is, sometimes, who do you go see? So if you're worried about these symptoms, right? Normally your first stop is to see a family doctor. And there are some family doctors who may be able to perform the diagnosis because they had received this training. But sometimes they won't be able to do the diagnosis. So they're going to refer you to a neurologist like Dr. Gauthier. Sometimes you may be referred to a geriatrician like Dr. Moret. Sometimes they may say you need to see a psychiatrist or a neuropsychiatrist, right? So it's not one clear pathway. So I just want to warn everybody of that, okay? That it's not a clear pathway of the diagnosis. So her behavioral problems were becoming more and more bizarre, right? But I kept blaming it on stress. Lo and behold, in 2006, the family doctor referred us to a neurologist. I was not prepared for the medical appointment. I did not have the answers to the questions of past medical history and all of that. And so that's why I say it's important to be prepared. I'm going to show you what dementia looks like now. I have 3 different images of my mother because what's hard, and I see this among families, when you're first diagnosed with the disease, you can't tell, right? The person still looks great. And at the time, I was being accused by some of my mother's friends of making it up. And when I meet families who just get the diagnosis and I'm talking to them about preparing for the future, preparing for help at home because you're going to require more physical care, people say, well, what are you talking about? They look fine, right? So this was my mother, and at my wedding was when she first started to tell me she felt different, okay? And in the images, I want you to pay attention to her eyes, because it's really in the eyes and the look that you can see the changes. So this was when she first started sensing something was different. So this was the first stage, okay? So she had been diagnosed now, and starting like a lot of the symptoms Dr. Gauthier said, the cognitive changes in behavioral, okay? So you're seeing the change, see the eyes? Now this is the next stage, okay? So this is the middle stage. At this stage, she could no longer perform her activities of daily living. She was no longer able to live home alone. And you see, she knows who I am, but at this stage, her communication skills are really changing. And you see how much more frail she has become, okay? And then the last stage, now the last stage of dementia is not like cancer. It's not like you have a few months. The last stage could represent years. So in her case, the last stage was 3 years, okay? This stage, she's in long-term care. She needs 24-hour assistance. She's no longer very verbal, kind of knows who I am, but not sure, frightens easily, okay? And so when you look at these images, you can probably understand how difficult it is for a family, because you're not only mourning the cognitive aspect of a person, but you're really mourning the whole physical changes that are happening, right? And this was just a few months before she passed away. And the question I also get a lot from families is, should we bring the children or grandchildren to see them in the long-term care home? You know, I would encourage you, if the children are comfortable in that environment, to visit occasionally. For my children, for the girls, it became a bit hard because, you know, in the long-term care, you have people, there's different smells and different sounds, and it could be disturbing. So it's really about going at your own, like what you may think is best, okay? So my mother passed away in May of 2016. And, you know, that's the other hard part with this, with I guess, any death of anybody. You know, society expects you to just brush it off and move on. But, you know, you can't just brush it off. And I was with my father by myself when he died. I was with my mother alone also when she died. And there's no support for grief, right? It's like, okay, the person's passed away. Like, let's just move on, right? And you can't just move on. So that was another whole aspect that I had to learn to cope with. So the term, it took me quite a few months to train to say this word, anosognosia. And this is one of the aspects of dementia that is kind of not very well known. And what is this? So so dementia causes another illness, which is called anosognosia. Now, it's not in everybody, but I would say about 60% of patients probably have anosognosia, where you as a family are noticing the changes. The family member is accusing you of cheating, stealing, you want to put me away, you never come and see me. They believe that the neighbor is something's going on, right? And you're saying to yourself, like, why are they saying this? This is unbelievable. They really believe. So it's kind of like a loss of insight into what's really going on, and it's also false beliefs, okay? And I cannot emphasize enough that if you are living the situation where the person is accusing you of things, please don't take it personally. I say this over and over again. Don't take it personally. Okay, because it's a true illness. They believe it, but it's not true. And it's just an unfortunate side effect of the disease, okay? I'm going to give you an example. So the seeds of dementia can be planted, besides the financial errors, the seeds of dementia could be planted years before a person is diagnosed. Once upon a time, I had a cat named Bunny. And I went away for the weekend with my husband at the time, and I left my son and this cat, and my mother loved this cat. So I go away for the weekend, I come back, and my father was still alive at the time, and I got my son, and I said, "Where's the cat?" And the cat was only 4 years old. And my mother says, "The cat is dead." And I said, "What do you mean the cat is dead?" Well, she took the cat to the vet and she put the cat down. And she put the cat down because she says the cat was scratching the wallpaper and my father didn't like it. So she decided, oh, I'm just going to put the cat down. Okay? Now, you can only imagine my shock, right? Like, it was the craziest. I was infuriated. But most families that I talk to when I first meet, there's often that one moment where you go, that's when it began. Okay? It could have begun with a unfortunate business investment if it was a man. It could have begun where a wife really, really is convinced that her husband is cheating on her or somebody's stealing money. But there's always that defining moment. And I had that aha moment a few years ago when I went, it began with the cat. Okay? So there's always one moment that you look back and go, that's when it started. And for me, that's when it started. Okay? So sadly, the disease will bring on some challenging behaviors, okay? People complain about, oh my gosh, they're repeating the same question over and over again. They're not happy, they're not comfortable. And so what I always say is, you have to remember one thing. As the disease moves through its course, the person is going to lose their ability to communicate, right? And as human beings, we all have needs. We want to express ourselves emotionally, physically. Imagine yourselves and you can no longer tell your family member how you're feeling, that you're hungry, that you're tired, that you're thirsty, that you don't like this music, that the kids are running around too much, that it's too loud. So when a person starts to lose their ability to communicate, what happens? They start to become aggressive, okay? Frustrated, right? So it's like you have to become a detective. And so my number one advice would be, you have to understand the profile of this person. What do they like and what do they not like? What are their triggers? What do they really enjoy? What makes them happy? And what doesn't make them happy, right? And if they're overstimulated, if they're in a home where you've got the television on and the radio on and families come over for big lunches or big dinners and everybody's talking at the same time and the kids are running around, they're probably going to become like, this is too much, right? So what is happening in the environment? You almost have to become a detective. When they're not verbal anymore, maybe they've been sitting too long in a chair in front of that television, or maybe when my mother was in a wheelchair, she bumped into a wall, so I went and I lifted up her pant leg and she had cut her leg. So what is going on, okay? The other thing that's important is to pick your battles, right? So if they repeat themselves 20 times a day, yes, that's what they do. It's the disease, okay? It's the disease. And how you're going to react, if you keep saying to them, well, don't you remember you asked me this? We talked about this yesterday. We did this, and why are you asking me this again? Watch how your reaction is. And they're doing what they're doing because they have dementia, right? And also, you have to let go of who they were and really embrace who they're becoming. Okay, they may not be able to set the table the way they did before, or play golf the way they did, or if they're changing their clothes and dressing 5 times a day. Like, it's about picking your battles. Who cares, okay? If what they are doing and what they are saying isn't hurting anybody, let it be, okay? Your role is to protect them, but you also have to let it go sometimes, right? And I also talk about using, like, we join their journey. So if they're telling the story about once upon a time, remember when we went on our honeymoon to Spain, and you're going, we didn't go to Spain, we went to Italy. Like, don't correct them. Who cares, right? Like, if you're constantly correcting them, you're going to start a battle, right? And I also talk about using the compassionate lie. And the compassionate lie is, if the information that you're going to give them has the possibility of causing a catastrophic reaction, don't do it. So if they ask you, oh, where happened to my wife? And the wife passed away 10 years ago. And you say, well, she's dead. And they're going to get all upset. Why don't you just say, oh, don't you remember she went back to visit her family in such and such a place, okay? But you have to think about the information. Because if you're going to tell them this information and it's going to be traumatic, why do it at some point, okay? The disease, as it evolves, becomes harder on the family than the person, right? So it's really about becoming creative. And again, remember what the tools, and that's why the book is so important, because we give you a lot of tips in the book. Everything that you're going to do today, you're going to have to adjust in 6 months, okay? Always, right? But think of their triggers. It's really simple. Like, what do they like and what do they not like, right? And if it's a bad day, what is going on? However, if there's going to be some significant behavioral issues, verbal aggression, physical aggression, paranoia, you must consult the doctor, okay? When it becomes very verbal aggression, physical, you have to make sure, paranoias, you must consult the doctor. If you're caring for somebody at home, again, in our book, we go through a lot of different aspects, but safety is of paramount importance. If a person living with dementia will suffer a fall or any type of physical trauma, it will make the disease progress. So as Dr. Gauthier mentioned, as it goes through its course, it will affect a person's mobility. So you will notice the different shuffle, right? And then dementia also impacts a person's vision. So when we're healthy, we have a good peripheral vision. As it progresses, the vision becomes narrower. So imagine the person wakes up in the middle of the night, they're confused, the area is not well lit, right? Could they fall? So every room in the house has different risks, okay? Especially loose carpeting, cords that are lying around. You know, the kitchen is a very dangerous room with the possibility of putting things in the microwave, mistaking a bottle of Lysol for olive oil. We talk about this, you know, because the ability to read and understand labels will change. And the bedroom, as Dr. Moret, I believe, is the one who said to me, most falls happen in the bedroom, right? You wake up at night, you're confused, you may have things beside the bed. And also in the bathroom has, and I'll show you in a minute, but the bathroom, I mean, in your bathrooms, do you have the anti-slip rugs in the bathtub? Is there an opportunity for a person to fall, right? So you have to really be careful. Dementia could also bring on what we call hoarding, okay? Because the brain doesn't have the ability to store anymore. It's like, you know, you take things out and this is an example most of the time for people that are living alone, okay? And this was a very good example. I had actually met a man about 10 years ago, a gentleman, and he was living alone. He was a former businessman. He thought he was still working, and this is really what his living room looked like. Like, he had piles and piles of papers and things everywhere, okay? And so it's just that the brain, like, they take things out, but they can't put it away. And bedrooms, you will often find the bedrooms again like this, you know, especially maybe my mother previously, when she was in a private long-term care, she liked to change her clothes many times a day, right? So they just take things out, throw it on the floor. So it creates a lot of chaos, right? But probably one of the most dangerous rooms in the house is, again, the bathroom and the medicine cabinet. A person who has dementia should not be taking their medications unsupervised, okay? There should be the family member assisting them to take the medications. Okay? And this is a frustration that happens often with families where they say, oh, I'm so mad, my mother, father, husband, wife, they won't take their pills. Okay? They should not be taking their pills alone. And because, first of all, they could forget to take their pills. They could take too many pills. This is a medicine cabinet of a woman who was living alone. There was expired medication. You know, you could be brushing your teeth with cortisone cream instead of toothpaste. So what I normally do, I used to go into homes and do security assessments. The first place I would go is the medicine cabinet and just clear out the pharmacy, okay? Sometimes people have this in their kitchen, it could be in the bedroom, but it's a dangerous place, okay? And the dispill doesn't work at some point because the person loses their ability to be able to read and understand. So Monday, 10 o'clock, or Tuesday, 2 p.m. doesn't mean anything, right? So it's really up to the family member to help. And then wandering, I mean, a week doesn't go by where we don't read in the news about somebody who's gone missing, right? Like, we hear it every week. I see it in the Journal de Montréal or somewhere. It's constant. And so people that are living alone, it is definitely a problem. I really believe, and also even with couples, it's not unusual for a couple where the healthy spouse will go and sleep in a separate bedroom because this person that has dementia is getting up too often. Unfortunately, they may start being incontinent in the bed, so the healthy spouse goes to another bedroom. So you really want to make sure that there's the security system is put on at night if you're going to sleep. I have my friend right now who's living alone who has Alzheimer's. I suggested to her son to buy the Apple AirTag, and he's put the AirTag on her house keys. So he's able to know at all times where she is. You could hide the Apple AirTag if somebody's still driving in a glove compartment. You could put it in their coat, in their purse, right? But the Apple AirTag, for those of you that don't know, it's like we use it more frequently now when we're traveling, right, to know where our luggage is. But it really just helps to locate a person if they were to go missing. The whole aspect of driving, that really needs to be done with the help of a doctor, okay? Because with driving, the way dementia impacts driving, you're no longer able to recognize yellow light, green light, right? I'm missing one, yellow light, green light, red light, and even walking, right? If somebody with dementia is walking frequently, to be able to stop at a stop sign, look both ways, the fear of pressing the gas pedal instead of the brake. So taking away a person's license needs to be hand in hand with the doctor. And the other part I would just want to really emphasize about safety is it impacts the eating of a person. So there's many people caring for somebody at home. The eating changes. It changes from the very beginning. So what you might see is that the person is no longer using a fork and knife to eat. They start eating with their hands, okay? Now that's fine, depending on what they're eating. But then you're going to see like they're having more and more trouble preparing their meals, having trouble eating, using the fork and knife. Now, if they're eating bread, it's not a problem, but if you start noticing that they're picking up the whole steak or that whole chicken breast and putting it in their mouth, that's a problem, right? And as time goes on, their ability to chew, to swallow changes. And oftentimes when they are transitioned to a residence, there's a nutritionist that's working with them to make sure that the food is pureed. But choking becomes a very big risk factor. So you have to be careful. And again, you'll start noticing the changes when they start using their hands more, okay? And unfortunately, it has an impact on the family as a whole. It causes obviously a lot of emotional strain. I see, family members where, the kids who are living in Montreal are the ones who are most responsible, obviously, for their parents, and then the ones out of town are not as responsible. Or even though if everybody's living in town, everybody feels like, oh, I'm the only one that's doing everything, and my brother or sister's not helping. When it's a spouse caring for a spouse, the whole relationship is changing. Once upon a time, you had this romantic relationship, and now you're becoming you're caring for your partner as if they were a child, right? And the communication is changing, and then you have to take care of their physical needs. So it causes, and then the financial aspect, it causes a tremendous amount of stress. So when I work with families, like when I do my consultation right now, I insist that all the family members are present in my consultation. Because if you're taking the time to become educated and your siblings or your other family members aren't, well, that causes a problem, right? So if I'm teaching you how to communicate properly with your family member, but the others are not, that's a problem, right? And we also talk often about how can we share the responsibilities as a family. Somebody could take care of the medical appointments, somebody could manage finances, somebody could, take care of managing the homes. So it's important to share, because if you don't share, resentment really comes in. So what's important as well is you have to accept what's happening. If you don't accept the diagnosis, you can't get to the next step of treatment and resources, right? If you stay in a state of denial, nothing's going to change. And as it progresses, I call it the anchoring effect. So the person who's living with the disease will only want their husband, wife, mother, or daughter to take care of them, right? We hear all the time that they don't want to have companion care or a caregiver, professional caregiver come in. That's normal. The problem is if you refuse to get help at home, you will burn out. You will. It's impossible to take care of a person 24 hours, 7 days a week. But it's normal that the longer you wait to get some help, that they're going to start anchoring onto you, okay? And again, as I mentioned earlier, it's hard to imagine that you're going to have to take on all these tasks. At the beginning, it's very cognitive. The person's, they're having some memory issues, behavior issues, but before you know it, they're having trouble dressing themselves, bathing themselves, and all of a sudden you find yourselves doing all of that, right? And we see it's oftentimes older people caring for older people. So it's important to recognize sooner than later how much help you need. And everybody wants to age at home, okay? Everybody wants to age at home. And I have worked with families where the parents have said to their kids, I swear to God, if you ever place me, I'm disinheriting you or I'm disowning you and all of that. But unfortunately, what COVID taught us is that in life, we have a plan A and we need a plan B, okay? And as much as we want to try to keep the person at home for as long as possible, it just may not be, because the primary caregiver may pass away before the person. It could become just too much. There could be behavioral issues. So it's very important to understand how to navigate our healthcare system, okay? So the only way to have access to the public health system, which we call the CHSLD, the public long-term care, is via the CLSC. Okay? You have to have a CLSC social worker assigned to your loved one. Okay? The only way to get a CLSC social worker is you must have a medical evaluation. If you don't have a medical evaluation, you cannot get CLSC services. So even more reason why it's important to make sure that you have a medical evaluation. Right now in Montreal, it will take you probably about 6 to 9 months to have a social worker come to assess the situation. Okay? The system is very overwhelmed. So that's just to come and do the assessment. Then you need to get care. Okay? That could take another few months. The waiting list right now in Montreal for the public healthcare system is a minimum of 2 years. Okay? So it's not like, oh, I've decided today that I can't take care of my loved one, and now they're going to go to Chateau Westmount. It doesn't work like that. Okay? Now, there are private residences, but I encourage everybody to do your homework because many of them will not take people that have behavioral issues. And in the private system, the cost of care can go up to $14,000 a month. Okay? So it's a lot of homework and research that people need to do. Okay? So imagine all of this. So you're dealing with the disease, you're dealing with now the cost of care, you're dealing with all of this responsibility, right? And the most common emotion that I see with caregivers is anger, okay? You're angry. You're angry at the disease. You're angry at, you know, what your mother, father, husband, or wife has lost. You're angry at what you've lost. You're angry because I was always angry because I'm like, oh my God, I can't believe my mother took care of my father his whole life and now this has happened to her. Or I can't believe that this has happened to me. I have 3 young kids. I have my husband. Like, I don't want this, right? I hear from caregivers, I don't want to do this. I don't want to do this, right? So anger is a very common emotion, okay? And sometimes people are caring for somebody that they don't like. Like they're in a situation where they don't like their mother, father, husband, or wife. They don't want to be stuck in this position, right? But I just want you to know anger is a very common emotion. And, you know, we especially as women, we're all thinking, well, I don't need help. I can do this myself, right? And that was my problem, is like I kept thinking I was superwoman, right? I can be the best mother, best wife, best member of the community, best friend, best this, best that, right? But I wasn't, right? I wasn't recognizing my own limitations. And everybody has a coping mechanism. And so, you know, when you're in a situation like this, sometimes you're in denial. You don't want to believe this is happening. And then you feel guilty. I'm not good enough. There's always the I'm not good enough, right? And then you're grieving. You're watching the changes that this person is going through. And then there's a lot of isolation and stigma. So there's a lot of cultural communities where they don't want to talk about dementia. You don't say that word. Or I don't want my friends to know. Don't tell them. Don't tell them, right? And then you feel anger. And then how you deal with all of this can lead to shame. So many people drink too much, smoke too much, take Ativan, eat. Every human being has a coping mechanism. Some people may be exercising too much. But you have to be careful that the coping mechanisms don't become addictions. So to finish, one of my most important messages is, like, if you don't take care of yourself and don't give yourself permission to take care of yourself, you can't take care of the person that you love, right? And we always put ourselves last. Like, oh no, like I can't possibly take an hour to go for a walk because I have to go visit my husband, my wife in the long-term care. Or no, I can't. I have to take them to the doctor's appointment, or I have to take care of my kids, and I can't. The problem is, if you don't take care of yourself, you're not going to do any justice to anybody, right? So I made that mistake. I let myself completely go, suffered a very significant burnout, right? And then I had to get medical attention and psychological support, and then you have to really rebuild yourself, right? But it's this habit we have to say, no, I'm going to take care of everybody else, and it doesn't matter about me, right? Until a crisis happens. So most of the time, families come to see me when a crisis has happened, when the caregiver has burnt out. So just to finish before I pass the mic to Dr. Moret, so as I mentioned earlier, education is of paramount importance, and we have created an incredible library of resources for you. So starting with the Dementia Companion Guide, which has so much information and more. We have an online education program, 10 modules that you can go at your own pace. We have webcasts. The big mandate of our program is to do community outreach. We have support groups for spouses. Most of it is all virtual. And our next big project is that we are hoping to take our program and be in the hospitals called caring spaces, where within the Division of Geriatric Medicine of the different hospitals within the McGill system, that caregivers and patients will receive a timely education and support that they need. So if you're interested in our resources, please go on our website. You all have the paper here on your chairs tonight. Our program is 100% supported by private donations from individuals and foundations and corporations. So please feel free to make a donation to our program. And we're very grateful to the Amelia Saputo Community Outreach for Dementia Care, which allows us to do this type of work that we do here today. So thank you very much, and I'd like to introduce my colleague, Dr. Moret. Here we go. There you go.
Good evening. I'm very pleased to be here to talk about modifiable risk factors of dementia. There is some hope, right? And I want to thank the invitation by Mrs. Smith. I have to acknowledge that the slides I'm going to be presenting were made and prepared by Dr. Gauthier, so thank you very much, Dr. Gauthier. There is some factors, though, that we cannot control. And you can guess that we cannot change our age that is progressing. And there is also our sex and our genetic background. I'm going to touch the first 3 slides about that, and later on will be those factors that we can modify, or we could try to modify. First thing is, unfortunately, as we progress in age, the chances of developing dementia or suffering from cognitive impairment increases. Though about 5% of the population above 65 have dementia, every 5 years this percentage doubles. So when you reach 85, then you have about 25 to 30% people of that age that have dementia. It can also happen to people below 65, although rare and usually associated with some genetic predisposition or some familial traits. About sex and gender, it is known that women have a slightly increased risk of dementia compared to men. Some of it can be explained by the fact that they live longer than men. So I told you before that is associated with aging, so it's more common in older women because they live longer. Some people might say that maybe it's the lack of estrogen, which is a possibility, but this have not been confirmed fully. For other types of dementia, other than Alzheimer's, the incidence of dementia, or prevalence of dementia, is about the same between men and women. And for people who are non-binary, this is a new term to say that they don't adhere to be a man or a woman. We don't know yet. It's still too early to have confirmation of the impact of dementia on this particular gender. In terms of genetics, we know that people who have alterations in certain of their genes predisposes them to have Alzheimer's dementia. These genes have been identified, PSEN1 and 2, and APP for amyloid precursor protein. Usually the diseases that contains genetic alterations happens early in life. There's also frontal temporal dementia that happens in about 2 to 5% of the cases of dementia that starts early in life. There is a familial contribution to it. I don't know if you are aware of it, but there is a protein that carries cholesterol to the brain called ApoE. There is 4 isoforms of it, one of which is ApoE4. Those who have ApoE4 are more predisposed, susceptible to develop dementia. But it is not because you have that particular ApoE4 in your body that you will develop necessarily dementia. In fact, there has been studies in people having that particular protein circulating in their body, but because they are aware of their increased risk, who do exercise, who eat healthy diets, they in fact do not develop dementia more than the rest of the population. So there is hopes there. These are the risk factors we cannot control. But in this particular slide, what is showing to you are those modifiable risk factors, and there is 14 of them. There is a group of experts called the Lancet Standing Commission that have searched scientific literature to find out what these risk factors consist of. They have made efforts to define at which point of our life course they are more important, and also their impact. And they determine these factors in early life, middle life, and late life. This is the 3 types of risk factors that are there. And I will go through each of them, so for you to understand what they consist of and how we can modify them in such a way to decrease the risk of developing dementia. The first one is less education. So we know that those who have had less than 12 years of schooling have an increased risk of dementia. And this increases the risk by 5%. Okay? So the message is to encourage your grandchildren to go complete at least their 12th grade, if possible, go to college, university, so that the risk of dementia is decreased. So the recommendation by this Lancet Standing Commission is that to ensure good quality education is available for all and encourage cognitively stimulating activities in middle life to protect cognition. Reason for that is part of your brain stimulation can also continue to occur while you are in your working, in your profession, because you receive a lot of stimulation there too. Hearing impairment. The strength of the risk of hearing impairment, it's very significant. It's one of the highest ones. And this is no longer at early age, but at middle age. So as soon as we notice that our hearing is not as accurate as it should be, we should look for a solution, because there is many factors associated with decreased hearing. We decrease interaction with others. We cannot stimulate our brain through conversations the same way. So the message here is that the recommendations is make hearing aids accessible for people with hearing loss and decrease harmful noise exposure to reduce hearing loss, because too much intense sounds can destroy our hearing apparatus. This is a new risk factor proposed in 2024. There's 2 new factors since 2020, one of which is the high values of low density lipoprotein. This is what we call the bad cholesterol. This type of cholesterol contributes to deposit the cholesterol in our arteries, which contributes to block them, and eventually to impair circulation to different organs, the heart, but also the brain. So it's a midlife risk factor that we can control by doing a blood test, and if it's elevated, then to proceed with medication. The most common one and most potent ones are the statins. A lot of people are taking them. And the impact of this bad cholesterol is significant, is 7%. So the recommendation is to detect and treat high HDL cholesterol at midlife. Depression. Depression is associated with development of dementia. And at the same time, if it never happened to you through life to have been depressed, but appears later in life, it might be a manifestation of dementia. And this has been already discussed by Dr. Gauthier, because the changes in the brain neurotransmitters associated with Alzheimer's also alters our mood, and the dementia can start by showing depression, but would be in most cases depression de novo, as we call it. However, it seems as if you treat depression, you might not only prevent the dementia, but there is even evidences that 10 years after an episode of dementia, of depression, if you ever never developed dementia, in fact, it protects you from further dementia. If ever you notice someone to be depressed, encourage the person to go for treatment. This way, we can reduce the incidence of dementia by 3%. In terms of traumatic brain injury, which happens with accidents, car accidents, motor vehicle accidents, and sports, you name it, it causes damage to the brain, and the accumulation of these damage eventually can lead to dementia as well. The responsibility is both individually, also policymakers, to prevent injuries by controlling the speed on the roads, by preventing people to be driving with alcohol intake, etc., and helmets in kids to prevent damage to the brain. And if you would control completely all the traumatic brain injuries, we would prevent dementia by another 3%. Physical inactivity. This is something that we can easily intervene ourselves. It's well recognized that being a sedentary contributes to decrease in general good health to start with, which affects, because exercise is needed for health, which affects any organ of the body. In fact, it's the best anti-aging therapeutics, best than most of my pills that I distribute prescribe to control certain diseases. What is recommended is to do 150 minutes of exercise per week of moderate intensity. Moderate means that you should feel some breathless by performing the exercise, like brisk walking, as opposed to a very slow pace in which you are rather, checking on the displays of the stores on St. Catherine Street. So you have to put an effort, but can be things such as moderate means you can do activities such as rattling your leaves, gardening, do some bicycle, not intense, and these activities are accessible to us. If possible, also if you join a community fitting activity with others, it's also very stimulatory. The risk associated with inactivity with appropriate exercise can be diminished by 2%. So we are all encouraged to do exercise because of general benefit to health. Diabetes. If you have diabetes, please make sure to control it to the maximum by adhering to a diet and following the medication. It contributes to 2% as well. Smoking is part of healthy aging. Get rid of some bad habits. We talked about inactivity, but smoking is also another habit that we should get rid of. There is no benefit at all by smoking. Some people find it to be a remedy to stress, but there is other ways of controlling the stress that is more healthy. Smoking affects all organs of the body, from the heart to the lungs, to the brain, to the kidneys. It's not easy to change habits, but there's so many programs. If ever someone is smoking that would like to get rid of this bad habit, just access MUHC, a smoking program, and you're going to have all the support you need to stop smoking. In any event, smoking contributes to 2% of the dementia, and we can control this risk factor. Hypertension. Hypertension is a bit of a silent killer in a sense that only if you have a crisis, you feel sick. Otherwise, it's totally asymptomatic, meaning unless you measure it, you don't know that you have high blood pressure. But when you go to a visit to the physician or even to pharmacy, you can take your blood pressure and verify the values. Values above 140 systolic millimeters of mercury increases the risk of having problems with circulation, including to the brain, in which case it increases the risk of dementia. Another vascular risk factor that can easily be controlled with medication, diet modifications, exercise, and decreases the risk by 2%. In terms of obesity, the weight, or the strength of the risk associated with obesity is less than with the others, but it's still something we can modify. And obesity is linked to diabetes, is linked to high blood pressure. So why don't we make an effort to maintain a healthy weight and decreases the risk, especially vascular risk factors. Excessive alcohol intake. We have means in our body to detoxificate ourselves from the alcohol. Alcohol is a bit toxic, so it's a question of the amount. To a certain extent, we can get rid of the alcohol by metabolizing it at the liver, but if there is too much of it, excess of it, then it can be that damageable to the brain. And it has been defined that the threshold is about 21 consumptions a week, meaning that, and you should not drink every day, not to become addicted to. So you should never go more than 3 consumptions, especially for men, per day, and for women, 2 consumptions. And this way we avoid the toxicity, and the contribution is about 1% to dementia. The next 3 factors are those associated with aging, and one of which is, I feel, to be particularly important is social isolation. The strength of this risk is considerable, is 5%. It's no longer 1% such as obesity. We're talking 5%, 5 times more. And it's something that is probably not enough recognized, especially in older persons that are homebound, etc. How much they can lose of their cognitive capacity because of lack of interactions with us. We derive so much benefit by being engaged, by being in contact with others. It stimulates the brain, it activates many areas of the brain, and this prevents dementia. So make an effort to be connected with others around you, participate in activities, participate in clubs and community gathering, and this way you can prevent isolation and protect yourself from dementia in a significant way. Air pollution. It has been recognized to contribute to dementia as well. We have less control of it because we require laws, but we can put pressure on governmental bodies in order to control the air pollution, which contributes by 3%. Visual loss is also a new recognized modifiable factor that was included in this recent commission, it's frequent in older people. 10 to 15% of older persons do have some visual impairment due to cataracts that have not been treated, glaucoma, macular degeneration, to name a few, and all of this can be reversible. And I have seen wonders after someone had that cataract repair, because all of a sudden they can see better and they become more participatory, more interactive with others, which stimulates the brain. The strength of the association is 2%. So we went through all of these factors, 14 of them, and if you sum each of them, then we arrive at about 45% of decreased risk of developing dementia. It's very good news. It's almost 50% reduction, and maybe there will be others in the future as we continue reviewing the literature and find which ones we can intervene. But this is very positive. And in terms of conclusion, so we have now tools and knowledge to support Canadians in reducing or delaying their risk of developing dementia. And much of it boils down to what is good for the heart is good to the brain. What it means that if we control the vascular risk factors that seems accessible, blood pressure, diabetes, obesity, smoking, I calculate that it accounts to about a third of the risk factors associated with dementia. So going to see your physician or have frequent visits to maintain your health and control the vascular risk factors pays off. Another warning here is that you can yourself contribute to the increase in knowledge and help the scientists to explore further these risk factors by participating in clinical trials and in research. And when you see your physician, I think it's important that he is sensitive enough to make recommendations to decrease these risk factors. We tend to apply a lot of prevention for heart disease or cancer, but brain is a bit neglected. So it's something of interest, of relevance to our health and our community. Thank you for your attention.
Thank you to our three speakers. So we do have time for questions for the people that are here in the hall. If you do have a question, I would ask that you ask it right into the mic standing there so that people at home and in the recording can also hear your questions. And our three speakers, you each have a mic beside you too, so for the answers.
Do not feel shy.
I think my question is directed to Dr. Gauthier. I want to know what my chance of becoming demented is. I'm in my early 80s. My father died of Lewy body disease, my mother of vascular dementia. What is my prognosis?
Hello.
Thank you for the question. It's appropriate for you to ask this, and I will not give you a personal answer, but I'll give you an answer that is important for all of us. We're trying to set up brain health clinics. It's a concept that we're going to pilot. We're discussing this now with various municipalities, exactly to know what is your risk and how far you should go with the prevention strategy that we've outlined. How aggressive should you be with your control of vascular risk factors? As you've heard, we can really make a difference if we follow all these 14 items. But as an investment for us throughout our life, we will be more motivated to follow the 14 recommendations if we're told your risk is higher than average person, which I think you'll agree is the case for you. But you're 80 now? Early 80s?
Early 80s.
Indeed. So age is important. And then the other question would be, how old were your parents, family members, when they had their symptoms? So you don't have to tell us. But that's the kind of question we would go through with you. And then there would be a blood test that we've talked about briefly called ApoE4. It's a test that we can do, cheek swab or just blood. And that's one biological variable that we can add to the discussion. So let's say you're 4-4, you got double dose of the gene that increased the risk, you would be in a special category. Now, the fact that you're 80 plus with no symptom, lucky you, you've done something really right if you were double 4, okay? Because most people with double 4 would have symptoms already. If you have only one copy, as you've heard from Dr. Moret, we already know that the modifiable risk factors offset that risk, genetic risk, if you have only one copy, which is 15% of the population. So in this room, 15% is what, 1 in 6? Has one copy of that gene that makes you more at risk. But just the fact that you're here tonight and you walked here lowers the risk. And you listen to Dr. Moret for the other risk factors. So thank you for your question. Yeah. It's actually a dream we have. It's quite strongly put forward in Europe. Dr. Frisoni in Switzerland is pushing hard, and people in England also, but they have no money to fund this. So we'll have to discuss it among ourselves. Can we get nurses to actually run these risk assessment clinics? And like we do for foot care, diabetes management, I think we'll have to go with the nurses for the main way to support this strategy. So your question is perfectly timely, Madame, and that's what we hope to do in the near future. Merci.
Thank you.
Merci. You want to add something, José?
No, I think a lot have been said already, and one efficient way is indeed to have the nursings doing the screening. Yeah, because otherwise there's not enough physicians to spend all the time in this particular aspect. Yeah.
Je dois baisser ça. Good evening. I want to know if there are ways to reverse the flow of dementia. I will explain. I've been diagnosed with it, and I have tons of pills, but I wonder if there is a redeeming factor that could reverse the trend of it. And if there is, besides ignoring it or denying it, if there is something that can be done.
I have a brief answer, but I will ask Dr. Moret to really say more about that. It's all the other things in your body that can be improved. So if you have a problem with your heart, your kidneys, if you have
tons of pills.
No, I'm saying you may have mild dementia, but there are other things happening in your body that can be helped. That's why the full geriatric assessment is so important. In terms of medicines, I've mentioned briefly, there are some that we have in pharmacies that regular family doctors can prescribe. They do help symptoms, and we've learned to use them well. And I will not say more about the ones that are coming because they're not yet approved in Canada, and there are others that may not reverse but stabilize progression. Josie, you want to say something about comorbidities?
Yes, I can add something. Is that, there is no cure, and the medications you have available, they have not been shown to change the trajectory. But we can play with other risk factors and chronic diseases that you might have, so that by controlling these other diseases, we can prevent somehow the progression of dementia. I'll give you an example. Let's say that you have high blood pressure. I don't know if you do have it, but if you do have high blood pressure, by controlling it well, there is evidences to show that it will prevent the rate at which the dementia is progressing, which was one of your questions.
My question is about reversing it.
Yes. As there is no cure yet, we're not there yet, but there is hopes for the future. Dr. Gauthier, he did mention that there is new medications that are not yet accepted in Canada, but we have hopes that these new disease modifiers, as we call it, can then change the trajectory, can change the progression, the rate of progressing. And let's hope one day we can stop the progression completely. What is lost, though. We cannot go back, But if we start a treatment that has a cure, then, as was presented by Mrs. Webster, the disease continues to progress, and we have more and more losses in terms of capacity, doing our self-care and solving the finances and the other things we do that is part of usual life. So by the mere fact of stopping the progression is already a big gain, Yeah.
Maybe I'll just finish by adding that very well supervised physical activity can actually improve symptoms that you have, and even brain regions grow back. That's been shown by Dr. Louis Bérère at the Institut de Cardiologie de Montréal. And you can actually join a program partly funded by the Saputo family, by the way.
Quel programme allez dire? C'était de Montréal? À quelle université?
EPIC, l'Institut de cardiologie de Montréal.
Yeah.
Ils font la recherche là-bas.
Oui,
Ils font la recherche
exactement.
là-bas.
Mais ils utilisent beaucoup l'activité physique, mais pour chercher des bénéfices. We are talking in French, right? I don't know.
Yeah.
Just to reach benefit, you need to do at a moderate degree of exercise, more than just walking on a flat surface. You have to increase your speed. You have to stimulate your muscles more to derive benefit to the brain.
Actually, that was one of the big surprises of the past few years. Is the hippocampus I keep talking to you about that shrinks with age. It actually grows back to some degree with the physical exercise done with supervision. And Dr. Louis Bérère is one of the world leaders. Yeah. So sign up for EPIC, Madame. They'll actually give you cookies, like we do here.
I have to sign up.
Saputo Foundation. Thank you.
C'est vrai? Merci beaucoup.
Très bien.
Actually, getting to the microphone is quite an exercise, isn't it?
I must say, after spending 2 hours sitting, it needs a kick to get out of the chair.
This is on your philosophy of feeding, say, an elderly woman, 96 years old, who has very poor hearing and very poor vision. However, well, she says, I'm confused fairly often. Well, the point is, she's in a residence, I'm in a residence. The people who are servers will come around and rather than ask her, they'll say, well, we're having ice cream. Oh, yeah. Others all say, oh, yes, she likes ice cream. And so she has no choice. And one of the beautiful things about our residents is there always are choices. You know, you can have pork or chicken or whatever. So I'm asking, first of all, about whether the servers need to give her a choice, or what do you think? And the second question is, should they push her when she puts her hand up? Should they keep on trying to? Those two questions.
Well, yes, certainly. I mean, if I would lose my hearing, and my vision, I would get confused, you know?
Yeah.
So we need the input.
Well, this was, or still is, well, I don't know, was a very bright woman.
Yes, yes. And she's still very wise. It's just that because she doesn't hear properly or doesn't see, it affects our
Absolutely.
capacity, you know.
Absolutely.
We should try to overcome these limitations with appropriate treatments, hearing aids, and see if we can improve her eyesight. Now, in terms of the food, what you just said is important. In fact, the fact that there is a choice on the menu is a very good thing.
Yes.
To allow her to choose what she likes the most.
Stimulation?
It is stimulation. She's probably lacking stimulation because she doesn't hear well. But if we could overcome that, we would probably give her a little bit more energy, stimulation, interest, and she would be more participatory. It is why isolation is so bad for older people, you know.
And she is isolated,
Yeah.
unfortunately.
Yes, unfortunately.
Yeah.
We should,
I mean, she has the opportunity, but because of these losses,
we can overcome some of it by showing our empathy, the fact that we care, the fact that we take time to spend with that person. This can compensate a lot, you know. Yeah.
well, the other question was about, for instance, my mother died at 97. She very slowly just stopped eating. And I had Aunt Minerva who did the same thing. So, I mean, should we try and make sure they get enough vitamins or enough protein or do we let them gradually eat less and less?
Well, I think that we need to reach an understanding. Yeah, good, Danielle. This is incredible. So I'll bring you with me to the hospital to help my clientele. No, I was just saying we need to see what the person wishes, you know, because you reach a point that everything is such a struggle, so that comfort becomes more important than pushing some calories in. Yes. We do our job of encouraging. We have to encourage, you have to support. But if you see that is also a reality that we cannot overcome, we would create more damage by pushing how do you call that, traveling food in, right? And then, but this doesn't prevent you from always showing interest and that you care for that person. And this is also food, it's food for the spirit. Yeah.
Thank you very, very much.
My pleasure.
So I was just going to say we're getting very close to the end of our time. So I'll do one final question, and then maybe we can share some of the contact information that's on the screen. So we'll take one last question before ending. Yeah.
First of all, I'm going to take 3.5 seconds to say thank you very, very much. It was very, very informative, very encouraging, very up to date, because we hear so many blah, 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 which has no proof of being true. So thank you very, very much. So one question, how long is the YouTube, how long is going to stay on the YouTube, your conference? Forever, forever. And here there is anything that you wrote, something in the little booklet? Oh, that's wonderful. So the information is going to be here. And now my tiny question, genetic, are you sure that it's not genetic? Because I read somewhere that it is not in the gene that you can have Alzheimer or whatever it is. So can you answer me, please?
I'll summarize what was said by Dr. Moret, because it's a question I always get. So the short answer is there's very few genes that cause Alzheimer. They're very rare. And it's usually families that affect every generation. It's a dominant gene. So you 50% chance or risk at birth. And we know where the families are in Quebec and Ontario. We have actually a registry of that. And their symptoms start around age 40. The youngest group in the world with familial Alzheimer, the youngest one is in Colombia, age 30. And they were studied in a very special way. So the other gene we talked about is ApoE4. That's, everybody has a copy of 3332, 3444. As I said, at least 15% of us has one copy of number 4, which makes you a little more at risk. Not just Alzheimer, Parkinson. If you have a head injury, it takes longer to recover. It's not specific to Alzheimer. If you have double 4, that's 3% of the population outside Japan, very rare in Japan. That's a higher level of risk. And that's would cause symptoms around age 70 instead of 85, just to show you the impact of that double gene. So that's it. The new medications that are coming, if they're approved in Canada, we would have to do this genetic test, because if you have double 4, it's not safe to take those medicines. They're just too strong for your brain. You'll have tons of side effects. But there will be other medicines for those double 4. For the average person with Alzheimer around age 65 to 75, they have one copy, so they'll be getting those medicines if there's no other contraindication. And finally, as the young lady was asking earlier, can you get yourself a risk assessment at age 40, 60, 80? Yeah, probably we would do the genetic testing, but it would have to be carefully explained what it means. It's just a risk factor, not a cause. Thank you for your question.
Thank
Merci,
you
madame.
very, very much. Thank you.
Daniel, if I could just say one final word. First of all, our team there, for those people that have not received a booklet, please go and take a booklet. And if you have friends that were not able to make it here tonight that you think would really appreciate having a booklet, please take a booklet for them. And it's thanks to the Grace Dart Foundation that we are able to have this incredible resource. So I know Diana and Maria would be very happy to hand it out. To this lovely woman who came and asked the question at the very beginning, first of all, I see you with your beautiful family that is here with you. My words of advice to you is just live your life, okay? Live your life. If there's anything that you've ever wanted to do, travel anywhere, live your best life, okay? Because we don't know what's going to happen, right? And so if there's something that you haven't yet done, a place you haven't traveled, something you haven't seen, just live your life. Okay, because a diagnosis of dementia, although a difficult one, but you're still very capable, very fine, and we don't know what could happen, right? So live your best life, okay?
Thank you very much to everyone for attending, and a special thank you to Dr. Gauthier, Dr. Moret, and Miss Claire Webster. And again, thank you everyone for being here. Have a lovely evening, and don't forget to check out the pamphlets and booklets in the back. Thank you.